So you are going to meet if Y2 wants to learn about bridging thromboprophylaxis, about a patient who is 45-year-old smoker with BMI of 40 and weight of 110, endometrial cancer stage 1, posted for laparoscopic hysterectomy. She has a past history of DVT, and she's a known case of antithrombin 3 deficiency. She is on a new oral anticoagulant, rivaroxaban, and posted for total abdominal hysterectomy. Her creatinine clearance is 96 ml per minute, and the following chart have been included about stratification and bridging thromboprophylaxis. And this is the protocol available. And when you are in the exam, you will find this local protocol present outside the cubicle and inside as well. So what we need to do, first of all, as a teaching station, you will welcome your colleague and ask him if he is facing any problem or facing any difficulty, offer your help and support. Ask him why exactly or specifically he wants to learn about bridging thromboprophylaxis and what he knows about that. Then appreciate his concern and put an agenda and explain why we need to bridge or shift this patient. What is bridging thromboprophylaxis means and why we need it and what is the importance of that. So first of all, what's the meaning of bridging thromboprophylaxis? In a simple way, when we have a patient who have a previous history of VTE, for example, okay, and he received his treatment in the past in the acute event, and then they decided to put him on a long-term anticoagulant, like any patient who is having AF, for example. So this patient is having high liability to develop clots, stroke, and VTE. So they put her on oral anticoagulants, okay? And in the past we were, or still they are using it, but is not to much extent, is the warfarin, is the most common anticoagulant or oral anticoagulant used. And we all know how to bridge the patient who are on warfarin when they are going to have a surgery. Okay, so nowadays the patients are being treated with the new category of oral anticoagulant, which differs from warfarin. I will tell you what is the difference between warfarin and these new oral anticoagulants so that we can get the idea why we are doing that. So warfarin is oral anticoagulant, but it is long-acting, and also it starts to work after 3 days from the first tablet. So if I'm giving the patient, for example, if today is Friday and I'm giving the patient the first tablet today, she took Friday, Saturday, Sunday, on Monday I will get the effect of today's tablet. So from Friday till Monday, the patient is not protected at all. She can develop clots. Okay? So, and if we stop warfarin, the patient still has the risk of bleeding. You know, anticoagulants are the drugs which thin the blood, which increase the liability of bleeding or bleeding risk. So if I stop warfarin today, on Friday, I will still in a risk to bleed for up to 5 days. Okay, so if I'm on warfarin, for example, and I'm planned for a surgery on Monday, I should stop my warfarin at least 5 to 6 days before my surgery. Okay, and I have to start another short-acting anticoagulant after 3 days from stopping my warfarin to keep me protected all the time. And I will make my last dose of low molecular weight heparin, which I'm using as a replacement to protect me. My last dose should be 24 hours before my surgery because I'm taking the therapeutic dose, not the prophylactic dose. And then what will happen? I will go for my surgery, and after that, if I started warfarin alone, I will not be protected. I can develop clots after the surgery in spite taking warfarin because it takes time to start its action. So it takes up to 3 to 4 days to start its action. So I need to start side by side low molecular weight heparin along with the warfarin together until I have the effect of warfarin. Then I can stop my low molecular weight heparin. So this is what we call bridging in case the patient is using warfarin. So bridging means it's a replacement of the oral anticoagulant with another one which is short-acting alternative. Mostly it's heparin or low molecular weight heparin. And this is happening in the patient who is planned to have a surgery. Okay, so how we monitor if warfarin is giving its effect or no? By frequently measuring the INR level. Okay, what is the difference or what are the new oral anticoagulants and how they work? So the new oral anticoagulants, they are new forms. We call it the direct oral anticoagulant, like the rivaroxaban, which is in our case today, or apixaban. So it's like a group of drugs, okay? They act immediately after taking the tablet. So if I'm uh, decided to have anticoagulant today, oral anticoagulant, my doctor prescribed for me rivaroxaban, I took the tablet today, it's effective immediately. I don't need to wait for 3 days to take its effect, okay? And also, if I stop the tablet, its effect will go away at the same time. So we don't need, if the patient is coming as a pre-operative patient, we don't need to stop that medicine 5 days before or 6 days before the surgery. We just need to stop it 1 or 2 days before the surgery, okay? And we can resume it directly after the surgery, but when we assume that there is no risk of bleeding without putting any kind of low molecular weight heparin. If we suspect that the patient still have a risk of bleeding after the surgery, we will not resume that oral anticoagulant because it will work immediately. So we will defer it further until we confirm that the patient is okay. And during that period, we can use low molecular weight heparin to avoid the risk of developing clots after the surgery. Because it's short acting, we can stop it, and the risk of bleeding is much lesser than the oral anticoagulant. How to monitor the new oral anticoagulant if they are giving their effects or no? No need to do any INR or anything at all. Just we need to monitor the renal function test and liver function test annually. Why? Because these drugs tends to change concentration in the blood if the renal function is affected or liver function. It will increase the level of the drugs in the blood, so it will increase its effect on the patient. It's mainly the kidney function is doing that because they are excreted through the kidney. Why liver function is important? Because sometimes if the patient is hepatic or have any problem in the liver, then the clotting factors are not being formed well, so she will have more and more risk of bleeding. So we will, if we add on her this one as well, this will increase her risk of bleeding again. Okay, so that's the difference between both drugs, and why we need to know that, because about 1.5 million people in UK are in oral anticoagulant at the moment. From this 1.5 million people, 15% going to the surgery every year. So you may see patient who is taking anticoagulant and coming to you to do the pre-assessments, pre-operative assessments. So you need to do the bridging thromboprophylaxis for her. Okay, so that's the principle we work on. What we need to do in the station, first of all, when you are outside the cubicle and you have a case like that, whatever the case, just write down in the notebook you have the age of the patient, the BMI, the weight, every information here will have a value in the chart. So we write down everything in your notebook. Actually, you will see it inside the cubicle as well, but it's not good to read the question again inside. You can just put these important data in your notebook, and then when you go inside, or if it is online, I'm not sure if it is online for you, it will be shown in the screen, this protocol. Here, each hospital in UK has its own guidelines, or it's called the local protocol, local hospital protocol. So each hospital is putting the guideline and following it. It is not necessarily to be the national guidelines. So here he will bring you the local guideline of the hospital, and we will go through it. So first of all, when you introduce the information to the candidate, you tell him some information about the new oral anticoagulants and why they are advantages over the warfarin. It shows that the new oral anticoagulant is reducing the risk of the patient, the side effects of warfarin. So it's better to be used than warfarin, and also it's acting immediately and we can stop it. Its effect is rapidly going away once we stop it. Okay, it doesn't need any monitoring rather than annually renal functions and liver function test. Okay, so coming to that chart, you just follow the chart with the information you have from the patient, and then you see what we need to do. So first of all, identify indication for new oral anticoagulant. It was prevention of a stroke or non-valvular non-valvular AF or VTE treatment. So our patient was having in the past DVT, and she is a known case of antithrombin 3. So she is taking this rivaroxaban for that reason. So which one? So this one, new oral anticoagulant for VTE occurred more than 6 weeks. Okay, so we'll go down. Preoperative, is the operation minor or major? What do you think? It's total total abdominal hysterectomy, laparoscopic hysterectomy. It's a major operation. Okay, what's meant, he mentioned to you what's meant by minor and what's meant by major. Minor, it's like ophthalmological operation, dental procedure, these minor surgeries. So we have our patient on the major sector, which is cardiac, chest, or abdominal surgery. That's good. So we are here in the right side. So as I told you, the renal function is very important in monitoring these kinds of drugs. So we have our patient creatinine clearance. We know it's 96. It's mentioned in the station up. It's 96 ml per minute. So we'll see where the 96 fall in the rivaroxaban column here. So the first is telling if creatinine clearance is more than 80 ml per minute, which is our case. So rivaroxaban here will be stopped at least 48 hours before the surgery. So the timing of the last dose pre-procedure will be at 48 hours before the surgery, because her creatinine clearance is more than 96. Okay, if he changes, like if he give you any creatinine clearance for rivaroxaban, it will be the same. Okay, so all of them will be stopped 48 hours. If he changes the medication, like if she is taking dapagliflozin, this one, the other one, then the timing will be different. Okay, so rivaroxaban is 48 hours to be stopped before the surgery. Okay, coming again to the next step. So the patient had her surgery already, and post-operatively, we will assess the patient's bleeding risk and risk of VTE, because we need to assess both risks for that patient. Is she high risk for bleeding or high risk for VTE? So if hemostasis achieved and no further surgeries are planned, from day 0, we will restart our admission dose, our pre-admission dose about 6 to 8 hours after the wound closure. So we will start direct the new oral anticoagulant without starting any kind of heparin. Once we assume that there is no risk of bleeding, there is no planned surgery in the coming days, and this should be started about 6 to 8 hours after the surgery. But if we assume that still the patient at risk of bleeding, for example, the patient is still not well, or we suspect some problem during the surgery, or we expect that she may return back to theater by any means, here on the day of procedure, we need to start some heparin to remove the risk of VTE, and at the same time, we will not start the new oral anticoagulant here unless we clear this risk of bleeding and confirm that she will not have any other surgeries in the coming few days. So our hospital is using that, that's the local protocol. You can tell that this is the local protocol of our hospital. They are using deltapirin. There is no official type of heparin used. It depends on the local hospital use, and here the dose will be calculated according to the weight of the patient. So our patient weight is 110. So 110 will run in 700,000, 700, oh my God, 7,500 units once daily as a prophylactic dose. Okay, and here we will start it 6 to 12 hours after the surgery. Okay, so once the bleeding risk reduced, we will resume our new oral anticoagulant after the last dose of the heparin by 12 to 24 hours. Mostly we give it in the same time of the next heparin dose. For example, if you decided that the patient is still having a risk of bleeding, you started after 6 hours low molecular weight heparin. So the next day you assume that the patient is fine and we can exclude the bleeding risk. So instead of giving the heparin today, we will give the oral anticoagulant and she can continue on it. Okay, so it's just to go through the chart one by one, and it's very straightforward because it's not like a warfarin. It needs combination of drugs and no. Here it will work once you start it. So if you assume the patient doesn't have any risk of bleeding, there is no bridging at all. You just stop 2 days before surgery and resume it 6 hours after the surgery, and that's it. But if you think that the patient may be at risk of bleeding, then you will defer it until you exclude the risk of bleeding. Then here you will replace it with some prophylactic, not therapeutic, prophylactic dose of low molecular weight heparin, because you can't give a therapeutic dose in a patient who has risk of bleeding. You assume that this patient at risk of bleeding, that's why you give heparin. You give heparin as a prophylactic for VTE, not as a therapeutic thing. If it is a therapeutic, then we can give her own drugs. Okay? Yeah. Thank you.